speaker for the afternoon is Dr. Kalaivani Chellappan, University of Kebangsaan, Malaysia. Dr. Kalaivani Chellappan has been an associate professor in the Faculty of Electrical, Electronics and System Engineering, University of Kebangsaan, Malaysia since November 2011. She specializes in healthcare. Her current research interests are cardiovascular engineering modeling, Internet of Things in healthcare, and data modeling and analytics. A holistic knowledge in management, engineering technology, healthcare, and IT provides her the opportunity to be creative in supporting organizations to realize the modern empowerment in science. Talent building and management empowerment through sustainable knowledge are her core values embedded in all her project deliveries. We welcome you, ma'am. Over to you.
Thank you very much, Ms. Yamini, and also to Dr. Gitanjali for this invitation and opportunity for me to share some of my experience and also journey in research. Let me make it a little casual, not so formal today, because I saw many of our participants are students, and I hope the message that I would like to bring today through this topic will bring some insights and give a new opening or in research for the participants today. So my title today is on IoT empowerment in medication, adherence and compliance. Right. So when we talk about IoT, I think that is becoming a trend word today, and it is being used in many different applications. So how do we look at IoT as an empowerment in medication adherence and compliance? So that's before I go into this topic specifically, I would like to share why I pick up this topic and why am I working on this topic lately, right? So this is a little sharing on my journey, technology empowerment in sustainable healthcare. The journey started back in 2003 when I actually moved. Before that, I was working on more on virtual platforms, specifically into teaching, distance learning, remote learning, and also on the virtual laboratories to be used in premises or institutes which were not really having the physical laboratory for learning. So in 2003, my whole journey moved to healthcare, where I started working with non-invasive measurement, particularly in biosignals. Started with the first signal was portoplatismogram, PPG, then moving on to others like EEG, EMG, and ECG. So when we started working on non-invasive measurements, then we were like really looking at what are we going to do with this non-invasive measurement, because at that point of time, there was a lot of reluctance among clinicians to accept biosignals as a measurement tool or even a diagnosis, or in fact, so much even to start with screening. So it was like, is that reliable and is that dependable? How reliable is these signals? Because the technology at that point of time was still very infant, and it is like, how do artery affect signals? How do movement effects? How if I blink my eyes, how much effect is there? How do we clean this? Even though we do have all those tools to do denoising and so on, but there was a lot of questions. So at that point of time, our focus shifted a little to remote monitoring again, like what I did in my previous research in education. So we were trying to focus on remote monitoring, where we said, okay, in clinics, it may not need it, but it can be used in remote monitoring. So we ventured into remote monitoring, capturing data in remote places, assisting doctors to get data from areas which is not easily accessible. And then we again moved on online training. We looked at, okay, now we have these remote monitoring and people need support, and the focus on online training was on auditory and cognitive. So there was a project and funded by the government on the auditory and cognitive training. So we developed an online auditory cognitive training in the local language, because that was a barrier among the patients, where most system available at that point of time was more on the English language. So we developed a complete system from the word. We started with start developing the entire program, and we hope to launch this end of this year for people to use, especially elderly, where they need the training on auditory to keep their hearing at par. So from that, in 2014, from auditory, we shifted into a self-directed rehabilitation. We worked on a few projects for post-stroke, specific into certain like pinching. Pinch was the last part of rehabilitation for a stroke patient who have upper limb impairments, specifically on arm. So from self-directed rehab, then we moved a little on disease prediction in 2018, when there were a lot of needs in cardiovascular problem-based prediction. So in 2020, I think all of you know, we had this big challenge of pandemic. Again, there was a need for virtual monitoring in 2020. So we moved into virtual monitoring of patients to look at how their adherence and compliance to the treatment. And that's when we came across there's a real need for medicine adherence or medication adherence, and followed by treatment compliance. Because during the pandemic, we could see the real need where when there is a virtual monitoring, when there's distance, patients could not come to hospital as per the normal appointment. The appointment get extended. They only collect the medicine. In most of the case in Malaysia, we actually have the service from hospital to do the postage of the medication every 2 months to the home of the patient. So rather than the patient coming to the hospital, all those medications are actually posted to them through the postal services timely. So this could actually reduce the number of patients which is walking into the hospital, and to allow the distancing and also treatment for more needed patients, especially patients with COVID. So this is the whole journey, and why today I'm sharing this topic, right? So why medication adherence? That's the big question. Yeah? So when we look at medication adherence, practically it comes from the barriers to medication adherence. What are the different type of barriers? If you look at here, we have patient-specific barriers. It is very much maybe to a particular patient, their likings, their behavior, their personal matters, personal limitations, and so on. Then we can look at the next is the illness-specific barriers. For example, patients from cancer patients, stroke patients, or different type, even kidney failures, and so on. So the illness-specific barriers, it very much limits the medication adherence, because the patient capacity, the frustration, and the question they always have: am I going to survive if I take all this medication? Doctors told me that my survival is 75%, 50%, or 3 years, or 2 years. Do I really need to take this medication? So it is very subjective, and it's very challenging. The next is medication-specific barriers. The medication itself, it become a barrier for them to consume the medication, or even get the medication, or manage the medication. For example, for a diabetes patient who has actually need to take insulin physically through injection and so on. Then move to healthcare and system-specific barriers. We do have healthcare system and our hospitals, our healthcare systems, and so on. They have certain limitation. They may not be able to deliver the medication on time, or there's not enough stock, and so many other barriers are there. Social and culture-specific barriers. Yes, this is it. Also, I guess in Asian country, almost all countries, we do have these social and culture specific barriers, where we all, always have all these alternative medicine and complementary medicines that patients go for. And finally, logistics and financial barriers. This is another aspect which become barrier in medication adherence. Right. So how are we going to address every one of these, or how do we really move, and what we should do that will be the next challenge here? So when we look at medication, the first thing we want to look at the complexity. What is the medication adherence complexity? So long-term treatment of chronic illness includes the long-term use of pharmacotherapy. See, when a patient has been taking a medication, for example, if a diabetic patient or hypertension, if they are diagnosed for this at the age of 29 to 30, and they had to take this through maybe another 40 years in their life. So this is a complex situation. Someone who's going to take this medication continuously, and maybe the number of medicines is going to increase. The complexity in taking the medication, or even the outcome of this medication, is going to bring about a lot of challenges in them. Then we go on, medication are not effective in combating disease when their full benefits are often not realized, because approximately 50% of patients do not take their medication as prescribed. So you see, when overall, we as people, they talk to each other, they communicate, especially in the hospital, when they say, oh, I've been eating this medication for 30 years, but there's nothing happened to me, But they never say that I do not comply, or I do not adhere the medication, consumption as prescribed by the doctor. So these are the real complexity that we are looking at, and it's very, very human related, psychological related. So our first step that we are looking at is the medication adherence complexity. From there, we are moving into the entities that contributing to the poor medication adherence. Which are the entities? We are looking, the first is the patients. What are the limitations? Is suboptimal health literacy and lack of involvement in the treatment decision-making process. Most patients are not really being part of the decision-making process in their treatment. They are just instructed, okay, you have this disease, now you've got to take this medication, and you have to move with it. So we are not really getting them to really participate as part of the treatment decision-making process. Next is the physician-related challenges, perception of complex drug regimes, communication barriers, ineffective communication of information about adverse effects, and also provision of care by multiple physicians. Like in Malaysia, every time, let's say I have a 4-time appointment in a year, I will see 4 different doctors in all my 4 appointments. I will not be seeing the same physician if I go to the public hospital. So this is, again, it's a big barrier, because the information don't get to the patients at the same rate or the same manner or method. And also about the adverse effects. If adverse effects differ from individual to individual, male to female, and also age factor contributes to all these adverse effects. So for a physician to be very accurate, it's a big challenge. And the next is the healthcare systems related gaps, office visit time limitation, limit access to care, and lack of health information technology facilities. So all these are the entities that contribute to poor medication adherence. Now, moving from the entities, now the factors that contributing to poor medication adherence, we are looking at consequences for not adherence to prescribed medication by patient for both patient and the health care system are myriad and grave. It means like it has got many factors. It has got many different issues. It differs from individual to individual, settings from setting, disease to disease. And the number of parameters to be controlled, it's a huge challenge. So the three most important reasons reported from this behavior include feeling that they had recovered from their illness. You know, when someone is given a medication, the doctor said, okay, you need to complete this medication for the next 2 months or 3 months. Halfway through, they feel better, then say, oh, I'm good. I'm not going to continue this medication. I don't need it anymore. Or believe that their illness was of a spiritual origin and hence would not be amenable to orthodox medicine. This has been a big challenge in, like what I mentioned just now, in Asian countries. And finally, the side effects of the medication. When they start taking the medication, they have, for example, they have like swelling legs. They said, oh my God, this has created me another problem and I'm not going to continue this medication. So this is the obvious three most important reasons reported for the behavior of they have poor medication adherence, right? Now moving again to the challenges in medication. We saw the factors, we now look at the challenges here. So when we look at the challenges in medication, the behavior is extremely complex. Individuals' requirement, like what I mentioned just now, it is actually a multifactorial issues where they need improved adherence. The next is approximately 50% patients do not take as prescribed. Medication adherence is not exclusively the responsibility of patient. Patients think it is not their responsibility. It is, okay, if it's not their responsibility, whose responsibility is that? Say, in many cases, they think the hospital is the one who gave me this medication. So it's their responsibility, it's not my responsibility to ensure that I should take this medication timely. The next is the medication taking behavior is complex and involves patient, physician, and process components, especially post-operative or chronic disease like stroke and so on, like cancer. So it is not directly the patient, it is also involve other parties which are not physically be present with them all the time. So how do we communicate? How do we keep in touch with each other? These are the challenges again. Identification of non-adherence is challenging and requires specific interviewing skills. So now when we talk about interviewing skills, then we again creating another step or another challenge. How do I ask the questions? How do I really go and get those information that I want from the patient? So here I'm sharing some of this example, the type of questions that could always been asked by the clinicians. I know it must be difficult to take your medication regularly, you know, so they want to make the patient to feel good before they really ask the question. How often do you miss taking them? You know, so like when they ask such a layered question, we may not get the right answer from the patient. The next question is like, of the medication prescribed to you, which ones are you taking? most of the time the patient get confused and they are not able to give accurate answers, but somehow they will give you some answers. The next, of the medications you listed, which ones are you taking? And going on again, have you had to stop any of your medication for any reason? And when we ask such question, are we really going to get the truth, or are we going to get some kind of answers? Yeah. How often do you take medication X? So when was the last time you took medication X? So to be accurate, to tell the clinician when the real time or the last time they took the medication, it mostly impossible among most patients. So the last question can be, have you noticed any adverse effects from your medication? They may give you like 10 different, effects that has come, but how many of this is just because of the medication, or it's combination of other type of treatment, other type of complementary medicine they're taking, and so on. So this has really challenged the clinicians in ensuring the medication adherence among their patients. So, but anyhow, the responsibility, in medication adherence still is important to ensure the entire healthcare system to move on. We, as like biomedical engineers, we are trying to always develop or design new devices, new technology, new sensors, so more information can be captured, better diagnosis, screening, diagnosis, treatment, monitoring can be done. But end of the day, all these only materialize and provide a treatment compliance when there is appropriate medication adherence by the patient. So here we look at an enormous amount of research has resulted in developing medications with proven efficacy and also positive benefit to the risk profiles. But in all this while, yes, we really look at in Malaysia before the year 2005 or 2010, I could say to be more appropriate. It was always that, okay, I'm sick, I go to the hospital, I get the medication, I'm okay, I'm better now and all that. But see, beyond 2010, it's in the 21st century, the society has changed, and they are really, in this millennium, there's a new, greater focus on outcomes, the impact, the quality. Am I getting quality treatment? Am I getting an impactful healthcare, treatment, and so on? I'm spending the money, and I would like to have a reliable service. And people are really looking at quality of life. Even I am sick, I have a disease. Yes, I have a chronic disease. I'm a diabetes. I'm a hypertension, and this is going to be lasting in my life for as long as I am alive. But at the same time, there's something that I could do. I can treat myself. I can live a quality life like others if I do get a high quality treatment. So here is solutions, including encouraging a blame-free environment, opting for less frequent dosing, improving patient education, assessing health literacy, and also paying attention to rational, not adherence. For example, even myself, I'm under the hypertension medication. I've changed my medication at least 4 times before I really settle down with the right one, which doesn't give me many side effects, especially the leg swelling, which it's very, very uncomfortable. So that's where the responsibility is coming in, and making the medication adherence is more important. And assistance from web-based resources. Yes, we do have many web-based resources which provides us with a lot of information, and 90% of them come from the Western world. And when we try to adapt or we try to follow those practices, it may not really match in many scope, especially in the diet and the type of food that we could take. The climate is different, our genetics are different. So this is giving us a lot of challenge again. And we really have to look at how could we among the Asian community do have high quality healthcare services or impact. So however, we seem to have forgotten certain things, that between the former and the latter lies medication adherence. So medication adherence starts with treatment, followed by the adherence, then the outcome. So when we look at this whole process, how do I really address this issue? That I think the most important aspect of it. Making it possible, making it applicable, and making it reliable. And finally, there is an outcome. How do we really achieve this? So because of these barriers that we have talked about all this while to medication adherence, and it looks complex and varied, solution to improve adherence must be multifactorial. It cannot be a single thing that, okay, I just do this one change and this is going to help me. It's not. So we said we need to have connection on the and timing is very important. If I have to take the medication at 8 o'clock morning every day, I need to do it at 8 o'clock morning every day. I can't be taking today 8, tomorrow 9:30, the day after 11, and the day after 7:30, and then going back. And also the effect, especially in cardiovascular disease, medications must be taken at the same time consistently as much as possible for it to give you the best outcome. So then we connect this with something that we know and something that we have or you have, with some alarm, some reminder, and this is how we serve the community in improving that adherence in a complex environment. So when we looked at this, we also looked at strategies to improve. What are the strategies available currently to improve the medication adherence? So one of it is the therapeutic patient education, by providing photographs, videos, guidebook, get them to read, get them to watch the videos, and tell them that how important your adherence to medication. Yes, all these are good, nice, beautiful, but sustainability. Is this sustainable? When someone listens to it, are they going to keep it forever? Or are they going to like, okay, it's nice to watch, nice to hear, and nice to forget, you know? So that's the challenge being faced in this approach. The second approach is simplified treatment regimes. Once a day combined pharmacological agents and all this, but it's not applicable in all disease, especially in chronic disease or post-surgery treatments and so on. It is not so direct, or it is not as simple as that, because the pharma industry has to also come together in this solution. The next is minimizing treatment cost, considering providing generics, yes, so that encourage certain people to be compliant or adhere to the medication. Whoever has the financial limitations, they move. The next is reminder programs, emails, phone calls, text messages, and smartphone application. These has been been approached in the last 10 years at least. And that's improvement, but again, you know, it's found to be costly, and it's also personalization, and it really needs a consistent effort in ensuring this reminder program works. Moving next is maximizing placebo effects and minimizing nocebo effects. Again, it's not applicable across all different type of diseases and different type of people. And finally, is early follow-up visits and short-term treatment goals. All this is definitely good, but it's increasing the healthcare cost. So from the strategies here, our team has actually picked up the reminder program. So when we looked at now specifically into reminder, so then we started with the journal, where they have the personal health book, the pocket book, where the patient actually write down their daily medication routines. They also have other type of organizers like pill box timers, and their mobile apps and so on, and also the pillbox, which like for a week, 5 days, or for a month, or for 15 days, 2 weeks medication management and so on. So we looked at all the different type, and we realized that they are not connected. We are yet to have a multifactorial solution. They all still independent. They don't link to each other, and they work independently. So when patients start working on an independent system, it still creates the gap, and it's not closing the need of the medication adherence. So now that's how Internet of Things brought in as a reminder solution. Here we look at IoT wearables enable people to better understand their own health and allow physicians to remotely monitor. So that's the first thing that we looked at, where IoT it's enable people to personalize, to feel that they are part of this mission now, part of their health treatment. They understand their own health and allow physicians to remotely monitor them, and they now participating. I do remember just now, I say patients don't feel they are part of the decision making in their treatment. But when we use this technology provides them a room and give them the understanding that they are actually now part of the treatment process or the decision for the treatment. And what is important, or the advantage of IoT here, when we introduce this technology, the first thing we look at, we could do cost reduction. We can increase efficiency and productivity. We provide business opportunities to others. We bring experience to the customers in managing their own health. And also this allow mobility and agility among the patients. They can move, they can travel, they can go anywhere, and they feel safe. Someone is able to connect with them all the time. So this connectivity brought many change in belief among the patient and the physician in the hospital system practice. So this technology also enables companies to track the health and safety of their employees, which is especially useful for workers employed in the hazardous conditions. So that's where we saw, okay, now we have a technology that shows some promising change could brought in medication adherence. With that, we saw what are we addressing in medication adherence challenge. So we went on low medication compliance, moved on to low treatment success. So, and then high rate of readmission, increased length of stay, patients have to stay in the hospital longer, and then prolonged treatment. So end of the day, this whole thing come out as high healthcare cost. So how do we convince the stakeholders to take up this solution to do the medication adherence as a approach to have to lower the cost of the high healthcare as an overall? So this is our approach. Then we had the end-to-end IoT solution, where we started with the medication adherence manager. We have a compartment where they can actually place their medication. And this compartment comes with, I think this has been presented by my co-researcher, where he actually shared earlier in his presentation how they designed the medical adherence manager. And then this is connected to a mobile app and recorded in the cloud for further analysis. And this, the whole process, the reports, analysis, and so on, to be shared with the medical practitioners, the family members, caretakers, and any other individuals who are in the loop or in the process of providing input into medication adherence improvement. So we go on the concept of remind, record, report, and real-time monitoring, the 4R concept, which I will share about 2 case studies here for you. What are we really looking at? The first case study is the post-surgery recovery, where we look at increased treatment compliance, starting with admission, post-surgery hospitalization, early discharge, and then medication adherence manager go into a good recovery treatment compliance. So what are the current problems? Low percentage of surgery success. Example, we actually started this whole project with the cornea surgeon, who actually came up with us and said, Kalai, look here, I would be very interested in improving my surgery outcome with my patients, which is currently very low percentage. The quality of treatment, the compliance is very low. And we found that the biggest challenge is the medication adherence among the patients, because they have as minimum as 2 and maximum to 6 to 8 different type of eye drops on the post-surgery of cornea. And they are not able to keep up with the medication adherence, dropping the right medication at the right time. So this is where we really started this whole project. So low percentage of treatment compliance and readmission due to low medication adherence. And we came about with this solution where medicine adherence manager that able to assist timely medication consumption, keep caretakers and family informed, continuous monitoring by the medical advisors. And the results expected to is improved treatment compliance, early discharge from the hospitalization, higher medication adherence, and increased patient health and quality of life. So this is what we are targeting. Currently, we are among these cornea patients, cornea surgery patients. The second case we are looking at is on the non-communicable disease patient on the treatment compliance. When they do visit the hospitals for their treatment, and what are the problems looked upon in this group is non-adherence to medication, limitation in patient monitoring due to volume and location. Elderly age group was found to be the determinants of the non-adherence, because they forget, they can't remember the time, and they get mixed up with the medication they have. Normally they will remember by color, size, and so on, and they make a lot of mistakes. And the solution again provided is same, timely medicine consumption, keep caretakers and family informed, continuous monitoring. So now the doctors can really know, how, when, the timing, and how do they consume the medication. So the result is focusing on improved medicine adherence, improved treatment compliance, lowering cardiovascular disease-related admission, and increased patient health and also quality of life. Right. So again, we are really looking at how this helps in terms of patient management and their impact on the health management, health treatments, and also the medication in a long run. Right. So coming back to the multifactorial features for IoT activated medication, this is another aspect that we are really focusing is on the policies, because this is something new. We are providing a device which is connected to mobile app and also to a cloud solution, and we are providing them reports, and it's involved payment, subscription, and then they either rent or purchase the device. So we need to have very nice policies, granular level, and make both parties, whoever the party in this process, need comfortable, to have this entire process to be taken up. Because let's assume a patient rent a device and they broke it, they dropped it, and that needs to be replaced, need to be paid. and so on. So in the policy issues, it has to be all clearly stated and looked upon very detailed, so no parties are upset and this whole program doesn't drop or collapse. The next is the self-service capabilities. How much we need to be very transparent to the users, to the caretakers, to the doctors, to everyone who's going to use this device. What are the capabilities and understanding of the minimum knowledge or value or education that we expect from the patients? And then next is the third-party integration. Definitely, when it goes into the market, it's going to involve different parties in this. The hospital, the doctor, the patient, the device provider, the business, the whole ecosystem. It needs a proper link and a proper understanding. How do they work together in this whole ecosystem? Because this is something new, yeah, and electronically activated, and it is fragile, and it comes with a lot of data. And the data policies and how do they integrate this data between the different parties is very important. Today, I am not really sharing on the data analytics and the next part of the business or the next part of the healthcare solutions and healthcare, how healthcare industry is going to use the data that we're collecting from this device to manage the whole entire, it can be a real input to entire healthcare management and bring down the cost again. And then the next is the comprehensive dashboard, which is give the users sufficient information, reliable and meaningful. And finally, the adaptive authentication. This is what I said, how do a patient give allowance to other third party or their doctors, the hospital, to use their data and all those type of authentication. So that's like 5 very important factor to be looked upon when we want to bring this such research products to the market to facilitate the healthcare industry to move to the next step with a higher impact of treatment compliance, right? So we do look at our SDG impact on this, and we are picking up 2 SDGs, which is SDG 3, good health and well-being, to improve patient health and well-being by 75% by introducing this device. And the next is the SDG 12, where responsible consumption and production. We are looking at to reduce adverse impact on environment due to pharmaceutical wastage by 80%. So this what we are targeting by 2026 to ensure these 2 could be achieved at minimum in our own country before we're really looking at moving this out of Malaysia. Right, this is our team. We have a company and we have a team from the hospital. So we work together. And our Nova engineering team is actually our own students from our university who actually have a startup now to anchor this project. And like what you could see myself, I'm the technical advisor. Then we have the experienced ophthalmologists who actually kickstarted this idea. And we also have a neurologist in the team that we are looking at to introduce this to more clinics in our hospital setting. Right. So this is like the features and what we are currently offering with our device and called iMedic features. And we are still at very preliminary stage that we are moving into the market soon. Right. With that, thank you so much. And I'm happy to take up questions if there's any questions. Thank you.